and welcome to this EBP session on patient care documentation and athletic training. My name is Elizabeth Neal, and I'm a PhD candidate and doctoral fellow at Indiana State University. I'm completing my PhD in curriculum and instruction with an emphasis on athletic training education. And I'm excited to talk to you guys about some of the new and advances in athletic training documentation, and to talk about ways that we can improve or continue on quality documentation that you are completing. So as we begin today, I want to let you know that I have no disclosures. I have no conflicts of interest with the materials I will be giving, and the views are all my own. Additionally, the views are not necessarily those of my colleagues or Indiana State University. Lastly, I want you to use your discretion on any of the information that I give to you today. So as we begin, a result of this session, we're going to have learning outcomes. And so the first one is to identify common mistakes within your medical documentation. And I want you to take this session not as a way that I am bashing what you are doing or that you are a terrible athletic trainer in what you document, but rather that there are ways to continually improve and for us to always get better in something that we do. Second, we are going to facilitate measures of quality improvement, and that may be a term that's not familiar with you right now, but we'll talk about what that is and how to accomplish this, specifically for medical documentation for you to share with yourself, your peers, or the athletic training students that you work with. And lastly, you're going to demonstrate knowledge of healthcare informatics, including medical documentation best practice. So what is medical documentation? That's the whole reason you're here today, and it's probably something that you've already thought about before. And so as we continue on, why are you here today? So I'm sure your clinical education coordinator required this as part of your yearly preceptor training. I'm sure people also saw that there was 2 free EBP CEUs available, and so that's something that you latched on to with next year being a reporting year. But what I want to challenge you is to think about the continuing education that you do. Think about why you're choosing it, and realizing that medical documentation and that domain 5 of healthcare informatics and different parts of administration that people hate thinking about is so important too within your everyday practice as an athletic trainer. We're going to take a moment and reflect before we get into the what, why, and how of what medical documentation is. So I want you to think back to the last day that you provided patient care to whatever population you work with. How many people did you see throughout the day? Was it something that you were able to go in and document right away? Was it something that maybe you did at the end of the day, a day later, maybe a week down the road? Maybe you still haven't documented those patient cases yet. Let's think about the why. How busy were you that day? Think about the overall medical documentation that you did complete. Was it quality work? Is there a lot of details so another athletic trainer could see it? Is there some dates missing or times missing or information from an evaluation missing? Think about the positives that you did. And then take a moment and think about some of the things that you would like to improve. These are not necessarily things that you're going to be sharing, but I want you to keep this in the back of your mind as we go through this EBP home study. In August of 2017, the National Athletic Trainers Association put out the best practice guidelines for athletic training documentation. And although these are not as prescriptive as, say, PT's guidelines, they are a good general guidelines for athletic trainers to follow. And I was lucky enough to be a part of this work group and get to create this document. And it's within your home study, so you're able to click into it and actually read this document to kind of aid you in assisting in what you're going to know throughout the rest of the home study that we're going to go through. And so it gives you definitions and generalizability of ways to know what you should and shouldn't document for the patients that you see every day. Another thing I want to talk about early on is what exactly are we talking about with medical documentation? And this includes medical records as a whole. So oftentimes athletic trainers think about things such as initial evaluations, and that is what you think of with patient care documentation. But we also need to think about daily notes or discharge notes. We also need to think about communication that may occur that should be within the patient's record, any immunization forms that they have, a consent and release to treat, a full background of the patient's history, of anything that they have going on with them. And I think that this is important to keep in our minds as we're going through, because like I said, oftentimes we have that initial SOAP note, old format that we think about, and that's all that we do. And so as we continue with this home study today, we're going to talk about a lot of these different ways and what we can do to improve your patient care documentation. Before we get too in depth with the medical documentation, I want to start first about the purposes. So why do we document what we do? And there's a list of different things that we can do to be able to actually document our patient care. Let's hope this works. So before we get too in depth with medical documentation, I want to talk a little bit about the purpose of the documentation. So we can see that there's a long list here, and we're going to kind of work through these. So the first one is to provide an accurate and thorough medical record. So we know that our patients will come into our athletic training facilities and will maybe only have snippets of what we did here or there. But this is a large part of their whole medical history. And so this is something that being able to give our patients thorough medical records will be able to assist them throughout life when they may be having to deal with some of these injuries later on. Another purpose is communication with our referral source, such as a physician. Depending on how your documentation platform works, you may be able to share the information directly from your emergency medical record directly to your physician. And this can allow for secure communication as well as an accurate way to get the information to the physician rather than maybe through the patient. It also is a way for communication with other parties involved to the patient. So if you talk to a parent or if you talked with the patient, it's important to note these within the medical documentation to know that the communication went on. A huge one that I like to talk about is this next point. So this communication with coworkers and the continuity of care. And you may be an athletic trainer who works by yourself within a setting, and that is okay. So you're going to be the only person. But are you going to be at that job forever? What happens if you have a PRN or someone come work for you? And so it's hard if you don't have accurate and up-to-date medical records that patient is not going to be able to necessarily communicate what you did the day before or day after with the people who are helping to take care of them. Additionally, we know that there can be some issues if you work in a team setting and have multiple athletic trainers working with the same patient population, that if you don't have that accurate medical documentation, you're not able to know what happened the day before, the day a few days before in treatment. And so you may actually perform a treatment that was contraindicated, but you had no idea because there was no documentation. Another one, and this is oftentimes I think what a lot of athletic trainers think about, is it saves ourselves from liability litigation. So we need to remember that if it's not documented, the interaction never occurred. And this is very important. And so it's more than just trying to cover yourself and not get yourself sued. But this is a huge part. So anything that's not directly written into the medical documentation, that treatment did not occur. And the last one is to show our worth as athletic trainers. Depending on the emergency medical record, if you have one, some of them are able to completely show your value just by what you put in. Others, you're able to count your treatments and show the amount of work that you have saved, maybe a university or a secondary school, by having yourself there as an athletic trainer working. So we know that there's some governance, though, of protected health information, and I want to start here before we get too far into some of the whys, so that we can make sure our records are accurate and correct. So there's three different governing bodies that we're going to talk about. The first one's HIPAA, and this is the Health Insurance Portability and Accountability Act. And this started in 1996, and this is that privacy to your patient records. And so this is that piece of paper that you sign whenever you go to a hospital saying that your information will not be shared with anybody that you do not want it to be. The next governance we're going to talk about is FERPA, and that's the Family Education Rights and Privacy Act, and this is from 1974, so a little bit older, and this protects students' personal identifiable information. So a lot of times when we think of FERPA, we think of when you first went to college and you had to sign a piece of paper saying that mom or dad was able to see your grades. But we also need to remember that depending on the setting that you work in, your information may be covered under FERPA also. So if you're at a secondary school or a college even, those patient medical records are a part of FERPA's governing act. And so we actually have a combination of HIPAA and FERPA working together to protect the patient rights. And the last one is called High Tech. It is the Health Information Technology for Economic and Clinical Health. And this was created in 2009. And this deals with, as it says in its name, technology. So any type of privacy and security from electronic medical records. This also goes into the realm of if information is shown via social media or any other sort of mobile or electronic submission of the medical records. And so we know that these all work together to be able to protect the patient health. So we'll talk a little bit later in the home study about ways to ensure that we are taking every means possible to protect our patient information. We're now going to talk about the what, when, and how of documentation. So I first want to go through some of the information again that you read in the medical documentation for athletic training paper that was in this home study. And so we're going to talk first about what a patient encounter is. And I think this is important to first identify and define as we get into some of these what to document. So the way that the work group wrote it is a patient encounter is defined as any interaction with a patient when an athletic training service is provided or communication occurs. Communication is and is not limited to written, verbal, or electronic communication with an individual or entity. So let's think about the patient encounters that you see. So when people come into your athletic training facility and are asking for any sort of advice on an injury, this is still considered a patient encounter. So please keep that in the back of your mind as you're going through about what should and shouldn't be within the medical documentation. Additionally, something that needs to be documented is this change in a patient's status. So anytime that there's a change or a deviation other than the expected, this is when a complete evaluation should occur, including any sort of consultation or a measurement of status change. So we can think here about our clinician-reported outcome measures and our patient-reported outcome measures of things like range of motion, or maybe you use a generic one like the RAND 36 to see how a patient's health-related quality of life is affected. And so anytime that we have any of these informations, that's considered a change in patient status. And a lot of times this is where we think of our daily notes, but this doesn't necessarily have to be as in-depth for the daily notes. So we know that anytime a large patient change happens, that we need to complete another evaluation for the patient at hand. We're going to start with the initial evaluation, and I put up here the traditional subjective objective assessment plan. And there's a lot of controversy between, is this something that should be used or not? And I don't think that I am able to fully give you the best answer for this. I think it depends on what your setting is and what you're doing. So if you are working with an electronic medical record, the likelihood that you are going to see subjective objective assessment and plan is very minimal. Most likely you're going to see something that goes through and talks about maybe specifics. So maybe it'll ask you where the patient was injured, what body region, then specifically what segment of the body, and then it may go into specifically what injury do you think it is then, right or left side, questions like that, rather than the traditional of what we were all taught, SOAP. But I still think it's important to know the different parts of the SOAP note in order to get a good understanding of what is included within medical documentation. I also understand that some of you are still completing pencil and pen documentation, and this may be the only way that you are able to complete the encounter that you had. So in the subjective part, these are a little bit, have a little bit of continuity between the different places, so keep that in mind. But within subjective, when we're talking about what we see. So if you're coming and you notice that the patient's limping into your athletic training facility, that's something that's in the subjective part. And so if we know that the patient is showing maybe reporting a pain that's 5 out of 10, this is kind of one of those gray areas because it is a outcome that could be completed within the objective. But there's also no way of me saying, okay, this is exactly what a 5 is, so I'm going to put this in a very specific category. And so subjective is normally that background of what happened, what are they complaining of, anything else that you need to report about the encounter. As we move into the objective part, this is those specific. So these are clinician rated outcomes such as range of motion, manual muscle testing, any sort of other patient-reported outcomes that you complete. These all go in that objective spot. And within this objective spot, things should be quantifiable. So when we are talking about range of motion, I do not like to see, and especially when I work with my students, that their left hamstring extension, so hip extension, was within normal limits. And so as we're thinking about that, what is normal for that patient? Do we check both sides? I would rather have a goniometer out and say, I got 15 degrees of hip extension from this patient. And so being able to have that quantifiable information to go back and recheck the information and reassess later is very important. We can also do things such as swelling. So instead of just noting that there was swelling within the joint, using maybe like the figure 8 method around the ankle or having a tape measure with specific measurements around the knee is important to be able to know if there is an improvement. Then we go into our assessment, and this is something that a lot of people still struggle with within athletic training. We are allowed to give a diagnosis within athletic training in almost every state that we work, depending on your state's requirements. So oftentimes in this, do I think that you're going to be able to get the assessment every time? No. Do I think that you need to have a differential list that you have determined what could be wrong with the patient? Absolutely, because we need to be able to take that information and move on. And the last part that we're going to talk about is the plan. And this is something that oftentimes I think gets kind of overlooked. So within the plan, we want to look at the patient as a whole. So oftentimes as athletic trainers, we think, okay, my patient is a 22-year-old soccer player, and their main goal is to continue to play soccer. Well, that might not be their main goal. Maybe they hurt their shoulder and are concerned that they're not going to be able to help their parents who are a little bit older and aren't able to get around. Or maybe they're concerned that that ACL tear that they had in high school with a re-tear their freshman year is going to turn into osteoarthritis and they won't be able to run around or play with their kids. And so I think we need to talk right here specifically for patient-centered care and to note in the plan exactly what that means for the patient. Will that mean return to activity sometimes? Yes. Will that also sometimes be a combination of return to activity and return to activities of daily life? Absolutely. And I think it's important within this to think of those SMART goals that you created. So having something specific that they want to do, make it measurable. So make it so that way they have short-term and long-term goals so they're able to get back to their activity. That they have a specific thing that they want to get better, that it's attainable, realistic, and that it's also timely. And so thinking of these different aspects, what is best for this patient at that time? And like I said earlier, think of both long and short goals, because you're going to want something that the patient can do right then and there and can reassess every couple of days or every day and slightly get better. And then you're going to also want those longer goals. We're going to talk about some common errors in the initial diagnosis. So within this, a few of the common errors are failure to include the visit number. So if this is the very first time that John has walked into the athletic training facility to have this ankle injury evaluated, this is going to be the first one. We also know that people often forget to put treatment times in minutes. So if you performed, I iced him on a patient for 10 minutes on his right hamstring, that needs to be listed. Additionally, signing and dating entries is very important, and we often believe that electronic medical records are just going to take the place of this, but that's something that we need to make sure that we are not just relying on, that we are going in, if a student worked with us, I need the student and my name as the certified and the date that we did this. If anything is incorrect and you have already stated that medical documentation, you should never go back to that initial evaluation and change it. Put a new note in and state what the error was, maybe what the additional change was, and then sign and date that one. Like I said, documenting treatment, modality, procedures. If you're using any modalities or treatments, the parameters need to be listed. We also fail to reassess objective goals and data. So going back through and saying, hey, we wanted so you could walk up the stairs today without pain. Did you meet that? We also know that there's oftentimes a lack of a skilled assessment, or if we do things such as non-diagnostic, non-therapeutic, or repetitive. So don't have your patients go through the same exercises every day. Be able to give some more evidence-based practice and some up-to-date treatments on them. We're now going to talk about progress notes, and these are something that should be completed every time that you see a patient or an encounter. So if your patient came in yesterday and you evaluated them for a right ankle sprain and they came back in today for treatment, this progress note should happen. And this is an abbreviated SOAP note, so don't think that you have to go back through and completely reassess everything. But depending on the injury and depending on where the patient is at, there is some reassessment that is necessary every day within the progress notes. We also need to know within this changes in pain limitation and patient comment. So how is the patient feeling? I talked about patient-centered care, so involving the patient within this. How are they liking the rehab? Or if you put them on crutches yesterday, are they able to get around today? Talk about more of the limitations. So maybe they've now been a little bit more exposed and are aware of what's around them and what is hurting them. And so we need to think about this as we write that progress note. So if we tried something day one and our coworker comes in day two, that they're not just trying again the exact same thing you said. Same as within the initial notes, you're going to want to put any treatments provided and reassess as needed. We also need to make sure that we are documenting the home exercise programs and that is progressing them toward their goals. So if you use specific programs that you can find online that you can create an exercise program, that needs to be included within the medical documentation. If it's something that you have written up and have different programs already saved, also that should be included, that what they did and why, so that way you're able to see it. We also want to think of some interventions for the next visit and assessment of goals. So I firmly believe that patient care needs to happen day to day or treatment to treatment or time that you see them. But I think it's also important to have an idea of how the patient should be progressing and what are some things that you could use at further times. This next thing that we're going to talk about, that all communication must be documented, and I think this is something very important. So we talked already about that HIPAA, FERPA, and high-tech governance. And so we need to make sure that we are communicating to our patients in proper ways. So if we are faxing, making sure that we have fax cover sheets and that patient information is just not being seen. That if we have email, that we have a tag at the bottom of our email that notes in case of a wrong email that this is private record, to please not share this. We also need to note that about text. So text is very important because some forms of texting are actually not patient protected, and iMessage is one of these. So making sure that we are not texting private information to our patients. There are applications that are available that you are able to digitally communicate, but any type of communication like this that does occur, and if a patient sends us a test, these all need to be saved within the medical documentation. Another important part is a canceled appointment. So this is a little bit harder if you just have walk-in treatments, but this is something to note, that if you tell your patient to come in the next day and they don't come in, that this needs to be noted that they missed an appointment. Let's say that you are seeing your patient 2 times a week and they came on Tuesday, but then mixed the next 2 treatments. So that would be next Thursday and next Tuesday. That looks like you did not see the patient for almost 2 weeks. And that appears wrong, but rather we know the patient canceled 2 appointments. And so those need to be written. So every time a patient canceled, just something as simple as the patient, called the office and noted that they would not be able to attend treatment today is appropriate. We also need to talk about changes in work or participation status. So anytime the patient is able to, let's say they are an athlete and they're able to participate in a little bit of the warm-up drills, that needs to be noted. and used within the progress notes for the patient. And the last one we're going to talk about is a discharge note, and this is absolutely important to have. If you have a patient who does not have a discharge note, it looks like abandonment of care. And so this should happen after the patient is better. Should be there for any time there's a re-injury. That should be a new SOAP note. And you must do as what's on the screen, as you can see, their status, signing, dating, and the reason for the discharge. I oftentimes, when I worked at the secondary school, would actually discharge patients in between seasons of sports. So commonly you'll have a patient who maybe plays basketball in the winter and then, let's say, softball in the spring. And so there's that gap of time that you don't see them maybe. And so I like to re-get a new evaluation and note the patient's status at that exact time. Within medical documentation, we know that there should be abbreviations, but I also want to give caution to overusing them. So it's recommended from the work group that anytime that you use abbreviation, that the staff knows about it. And so what I recommend is that you come up with a group of abbreviations that you and your staff that you work with will use. Because if you look at this example of a meme here, and I know it's supposed to be funny, but reading through it, it's going to probably take some of you guys some time to realize what some of the abbreviations mean. And that's not a knock at you or your knowledge and your education. It's simply that these are not necessarily things that athletic trainers utilize all the time. Or you may have certain ones that you always will use, and more or less your clinic has determined that these are going to be appropriate. And so as you're going through, make sure that, like I said, you have that master list and that everyone knows these. When you have abbreviations, though, you always must use them. So for example, right here in the middle of the page, we have HX for history. So if you determine that HX is something you're going to utilize as a medical abbreviation, this has to be utilized for your whole entire clinic for any time you document. So having a staff meeting, if you have a larger group, or if you're the head athletic trainer somewhere, maybe putting that information down as the director that, hey, this is what we are going to do. Another aspect I always get asked a lot is on routine care. So what do I do? So let's put this scenario into life right now. Let's say you're an athletic trainer at a secondary school and the cross-country team wants to come foam roll, and you have a large amount of foam rolls in your athletic training facility. We know that the team will just come in, foam roll, and leave. You didn't really communicate with them. They just did their own thing. So what do we do in that case? So anytime that we have things such as stretching or taping, foam rolling, and wound care, these are all some of the really common questions. So let's tackle the foam rolling one that we talked about. So if the patient comes in and you do not interact with them, those do not need to be documented. Now let's say that your patient, let's use the taping example. So your football coach at the institution you work for requires that every person must be taped, and they have provided you the tape, and that's something that you're completing. This does not necessarily need to be documented in each patient's medical record for every single time. What I do recommend, though, is because patient care is given, to make a generic list. And these are possible within some electronic medical records where you can go in and you can simply just put a list of everyone who received that care for an injury that, or for something that's not injured, and more as like a way to prevent injury. If we get into stretching, that's something a little bit different between stretching and wound care. So especially anytime that you're hands-on with the patient, anytime you're providing care, that's where it gets a little bit grayer. So my advice, based on the literature and best practice, is anytime that there's wound care, that should be documented. We don't know what could happen down the road. There could be infection, there could have been something worse, the patient could have an allergic reaction to the topical ointment used. So anytime you have something type of wound care, that should be documented. With stretching, again, that's that kind of that gray area with taping, that if it's just routine and for someone who's not injured, it can go into a little bit more of a general list. But if this is something that's occurring often and something that the patients are injured for, then we do need to be documenting the care. Another question is, when should you document? And so my best answer to you is it should be completed immediately following the patient encounter or during it if you can. That's in the ideal perfect world, and I know that we all want to live there, but not necessarily can't. What I do say is it should be completed within 24 hours. If I were to give you a list of things today and told you to remember them tomorrow, how much of it would you actually remember? Even going as far as this EBP talk, if I'm talking to you today about it, and you're going to have to take the quiz at the end to get EBP credit, you're probably going to remember more today than if I had you take the quiz tomorrow or a week down the road and see what you remembered. So if we can get that documentation done within 24 hours, that's ideal. Another thing we want to think about is that this should be completed within a private space. So if you're an office with a closed door, or somewhere where there's not papers out on your desk or patients able to see your computer, because of the HIPAA and FERPA governances that we already talked about. So let's say that you're the sole athletic trainer at a secondary school and you're seeing a large amount of patients, and you're telling me, Beth, this is not possible. I can't keep up with half of the documentation you talked about, let alone doing it within 24 hours. Consider dictation, and this is something that I did not use immediately when I was certified, but it's an easy way, and we know that physicians have done it, to go back and remember some of those key details of range of motion or manual muscle testing that we may have a harder time remembering down the road if we do not remember right away. And there's a lot of different softwares that are able to keep dictation and to keep it HIPAA and FERPA compliant. So this is something that if you can't get to medical documentation immediately, so you don't have any memory lag, that I recommend dictation. We talked a little bit earlier about how you're completing this medical documentation, whether it's on pen and paper, electronic medical record, electronic health record, some of the different types. And back in 2009, I'm not sure if you were aware of this or not, but the American Recovery and Reinvestment Act mandated that as of January 1st, 2014, that all public and private healthcare providers must have an electronic health medical record in order to maintain Medicaid and Medicare reimbursement levels. And that was 4 years ago, and the fact that many of you may not know about it makes perfect sense, because most of the time athletic trainers do not bill for Medicaid or Medicare, and oftentimes are not able to. And so as we think about this, this was 4 years ago that we were requiring, in order to get government funding and reimbursement, that you had to have electronic records. So why are we not doing this within athletic training? And we know those answers simple, like I said, because we don't have to bill, especially for those services, and oftentimes don't bill for services. But I think it kind of puts us in a different boat with a different question. So athletic training is always so worried about keeping up with physical therapy, occupational therapy, or other allied health professions like that. So why are we not utilizing electronic medical records? We're going to talk about those a little bit here, and there's some different types. So I want to talk about the difference between an electronic medical record and an electronic health record. Within an electronic medical record, there are a large amount of different types, and if I started to name them, I'm sure I would still miss some of the electronic medical records that you have at your clinical site. These are records that you either are given or purchase for a fee, and you're able to put the patients into it, log their care, and can let a certain number of people in with the correct passwords to be able to have accounts and see into that electronic medical record. This is something that stays at your institution or your healthcare clinic or whatever you're working at. This is something that stays directly there. So it is not transferable from place to place. So if we have a high school student athlete who goes from the high school setting into the collegiate setting, that electronic medical record is stuck at their secondary school. But this is electronic record keeping. It is, there's a large amount of different types. Some are really easy to use and some are a little bit harder. And it depends on what you're interested in. There are some options that are available for free. And so if this is something that you're interested in, trying to find what fits you is very important. We also know that there's this electronic health record, and this is that overarching medical record that I talked about earlier that follows you. So a lot of systems, Minnesota has been leading the way with this electronic health record they are linked. So all your information is able to be in this system and can be linked to the different healthcare providers you've seen. And this is really important to think about for today's technology. So we have so much technology and so much has been adapting, and being able to have electronic health record or medical records where you're able to easily pull up a week of patient-rated outcomes and see the difference, or able to import the notes and easily see that Jane Doe had sprained that same ankle 3 years ago is really nice and convenient to have within one specific place. You also don't have to worry about the issues of documentation getting lost or seen or taken that you would with pen and paper. So some ways to do this. Here's an example of a mobile documentation unit, and it's a really convenient way to be able to keep the patient's computer. This can actually be something that you can look right in and are able to type directly into it and have that mobile card available. We also can know that within the, we talked a little bit earlier about the office, and so this should be something that medical records are done in private, are done immediately following, and done in a way that people are not able to see them. The next thing is that pen and paper documentation, and so this is what a lot of people still are using, and I think it's something that, although you may not think that you have another option, please try and seek out electronic medical records that are inexpensive or free, depending on what setting you're working in. And it's really hard to compare improvements, patient-rated outcomes, and it's very hard to access. So if we think about, if you have a patient perform 5 different outcome measures, you're going to have to manually look at all of them and pull them out of their record and see it. We also have some legality issues of, being able to see that documentation just sitting there and knowing that somebody could get into it, keeping it double locked, keeping the storage place, and properly disposing of it. We also know that continuity of care is hard. So if you have 10 different patients throughout the day that you want to take care of, then you're going to have to go back through and look at the different charts if you are not the person giving the care from the day before. So sign-in sheets are something I really want to talk about, and I understand and appreciate why people use them. They're convenient. You have a record of who comes into your clinic. But we need to make sure that we keep in mind of the information put on these. So when you go to the doctor and you sign your name and who you're seeing, that's one thing. But if you're asking a patient to put the body part that's injured, the time that they came in, the injury, whether they're coming in for treatment, evaluation, or whatever, we're getting into a very sticky situation legally because somebody is able to walk by. Let's think about it this way. Let's say that you're a secondary school athletic trainer and you have these sign-in sheets and a recruiting coach comes by and they see this list and they're able to know that somebody they are talking about has been seeing you. Maybe it's only for prevention, but we don't know that and they may not know that. We also have these issues with giant whiteboards in offices. So please keep in mind, do not put private medical information up there or have Johnny's whole rehab out on a whiteboard, because that's something that everyone can see. Knowing that people came to you, that's one thing, but knowing what they came for you and why, that's another, because we're worried about that HIPAA-FERPA violation. So having too much information on the sign-in sheets is an issue. And this is why I recommend the mobile documentation units that can just go around with you. You can type in, or depending on the luxuries you're able to have, some electronic medical records allows patients or student athletes to sign in, swipe an ID card, or many different ways of letting them know who was in your clinic today. And so although these are a great idea and very easy to do, that HIPAA-FERPA violation is just too important to be able to keep going and not allow these sheets to happen. And overall, like I said, this is for communication. We document to be able to keep that continuity of care between the patient, maybe their parents or other caregivers, other healthcare providers, coaches, whoever's involved. This is all very important to have this information together and be able to take care of our patient in the best possible way as a team. So now we're going to talk about the why and the why not of medical documentation. So the 3 main reasons athletic trainers state, based on the literature that they document, is for communication to monitor patient care and legal implications. And these are a study that Drs. Nottingham, Lamb, Kasamatsu, Appelheimer, and Bacon found that athletic trainers determine as the 3 most important reasons that they do document. And so we know that the top priority should be for improving patient care. So whatever we're doing within our documentation, we know that we want to make the patient the healthiest and the best and live the best life that we can. We also know that, and those are very similar to everything that we talked today, but there are some barriers to patient care. So maybe a lack of time, inadequate facility, faculty resources, a lack of accountability, or lack of personnel. And so I'm not sure what your reason for documentation, not being able to document is. It could be any of the ones above. We talked about the lack of accountability with not being able to determine HIPAA and FERPA, and nobody's looking at your medical records. And this is something that we really want to talk about. So who is going in and taking a look at your medical records? I'm sure that there's very few people that come in and actually see what's going on. And this is important because if you do not have this accountability, you're going to have no one that's there in order to know what you're actually doing. We also know that, like I said, lack of time, just not having enough people or resources is an issue. But keep that lack of accountability in your mind as we go through the rest of this. So within healthcare information technology, we know that there's a thing such as meaningful use, and this is where you're able to use digital health records to improve quality of care and to reduce any health disparities we have. And so we know that the government has already put $50 billion into healthcare information technology to continually improve these computerized efforts. And so kind of going back through, continuing to think about that idea of who is looking at our medical records, we move into third-party reimbursement. And the NATA has worked with 3 states, including Indiana, Ohio, and Wisconsin, to go together and determine who is able to get revenue as athletic trainers. And so we know that we're able to get this reimbursement. We know that it was a positive model that worked. And so as we go through, we need to continue to remember that in that case, healthcare governance such as like insurance companies will look through and will ensure that we have to have proper medical documentation in order to actually get reimbursed. Last, we know that anytime we document, it's for risk management. We talked about if it's not written down, it didn't happen. So there's that risk to the patient and that risk to the healthcare provider that is there and is very real if medical documentation doesn't occur. Very early on, we talked about quality improvement and what does that mean. So we're going to talk about quality improvement on a little bit of a different approach to help you. So we're going to talk about a PDSA cycle or a Plan, Do, Study, Act. So the very first thing we want to think about is planning. So what do we notice is wrong? So take a look at your athletic training facility. Look around, see what is happening and seeing what you need to do. So then we move, like I said, into that do. So have some sort of plan. Be able to go in and see what is going on. Move into that study component where you're able to, again, take a look. Did what we determine and change work? And then lastly, let's act upon it. So you guys performed a chart review that you had sent me, and you're going to you've already received your feedback or will be receiving it soon, where you're going to get this initial evaluation that you see, and then you're going to have gotten either a positive or a negative response. So if you did not have the patient goals listed, you received feedback that was worded such as there was no patient goals listed within the initial evaluation. And this is a way for quality improvement to happen. So you performed a chart review, and then I sent you back, after going through it, a response of whether you had it or not. And this is not something that I have to do, that I am special or privy to. It's just a way of implementing these quality improvements. And so you're able to actually go through and utilize something similar like this with your staff. In order for the EBP CEU, we've also created some quality improvement within here. So you know that there's a 6-week follow-up. So in 6 weeks, you're going to be asked to send me another piece of documentation. And so at that point, we can notice if there's any differences within the documentation that you did before or after and quantify that. And you know know that you are receiving, oh, nope, we're going to cut that. You're receiving this EBP CEU because you are a preceptor. So how does all of this work within being a preceptor? I wanted to make sure that you guys had a very good understanding and background of what medical documentation is before I expected you to go teach this to your students. So we're going to talk a little about the standards of education, and we can see that although these are just the list here, that there have been a few changes throughout the different editions. Currently now there's a large amount of standards that students must complete within their medical documentation and healthcare competency while they are in clinicals. And so it's important that we're reinforcing that clinical education from the information that they learned in their didactic school. And we want to think of that as one thing. So let's try to get the idea as preceptors that they're not learning one thing in the classroom and one thing in the clinic, that it's together their athletic training education. An important thing to talk about is the social learning theory. And so this meme's kind of a funny way of saying it, but if you watch somebody do something, are you able to learn it? And we know that this is true. So I am not implying here that your students are going to be able to magically learn how to do documentation just because you've completed it. What I'm saying is that they're going to be able to pick up your habits. So if you're someone who's completing documentation instantly, your students will see that and will see the value. If you're someone who does not put an emphasis on medical documentation, your students will not understand the importance of medical documentation and theoretically will be less likely to complete their own documentation when they are a certified athletic trainer. And so this is something that's very concerning to us as educators, that our students are not following in. And so making sure that you are modeling good behavior for your students is imperative as your work as a preceptor. We know that 90% of healthcare students state that their role models shape their attitudes and behaviors. So what are you doing to your students? Like I talked about, if you're documenting well, they're going to see that. They're also going to see your actions and words. So if you have a positive reinforcement toward medical documentation, that's going to be something that they also follow. And we know some current research has just been submitted to the Journal of Athletic Training and the Athletic Training Education Journal, knowing that we need students to be involved. We need for them to be able to have that time for documentation. And so a recent qual interview that happened, we were able to determine why they had students document. So some of their main intentions were for learning and competence. So having that idea of getting to genuinely determine what is medical documentation and be able to actually do it well. And then having that time to practice. So we want our students to be able to go in and have that time to learn. Imagine if you had never completed medical documentation and you were asked to do it for the first time as a certified athletic trainer in your transition to practice. That would be overwhelming, and it's setting them up for to fail. We also know that there was some deterrence within those attentions. So athletic trainers may have tried and wanted to do things well with the students, but they may have done something like double documentation, where the student wrote out on a piece of paper the documentation, and then you typed in the electronic health record. Some other issues that came up within the intentions is that we only allow upper level students to document. And I think this is a huge issue for students. So if you're not being able to do things your whole entire career as an athletic training student, then all of a sudden are put into it at the end, you're not going to be very competent at what you're doing. And so getting the students involved, teaching them, getting them to be allowed to do as much as they know is a very important way. Maybe they can only complete a part of the evaluation and you're sitting there watching them. That's a great start. We also found that mentorship was very important. So some logistics, so being able to be there and watch the student and then come read with them is important. We also know that there's a degree of oversight that must occur. So students can't just sign and complete medical documentation on their own, but they also don't need you to sit over top of them and do it. So it's important to get that value of looking at that balance of looking at their work, but still allowing them to complete the medical documentation. And we touched on it a little bit, but why do you double the work? So we're already busy. We're already in a time that we say we may not have the time to complete the documentation. So let's streamline the process. Allow students to type into your EMR and you check and sign before they save it, or everything is completed into one file, or whatever it means to you at your place. Try to eliminate some of the extra workload and excess work that you don't need to do. So I want to thank you for listening to the video portion of this home study. My contact information has been given to you within the home study. So if you have any questions, please don't hesitate to reach out at any time. I'd be happy to chat with you, talk with you, come up with ways to help improve the documentation at your setting, and to just give you the best experience possible, and also to help the continuity of care of your patients. So thank you for giving me the time to speak with you today, and please don't hesitate to contact me.